Hello everyone, this is second part of approach to Hepatosplenomegaly. So in the first part I have already covered the GIT examination for the liver spleen and when you will label the normal liver and spleen. Other part I am going to cover today. So when you label the splenomegaly, whenever spleen is palpable, then you have to categorize either mild splenomegaly or moderate or the massive huge splenomegaly. So according to the size, if size is less than 2 cm, we label as a mild, moderate when between 3 to 7 cm, massive huge splenomegaly when the size is more than 7 cm. Another is the Hackett classification for the splenomegaly to grade the severity. So there are grade from 0 to 5. When spleen is not palpable even on deep inspiration, we label as a grade 0. Grade 1 means spleen is palpable below costal margin, usually on deep inspiration. So here in this image you can see it is grade 1 and palpable with the deep inspiration. Grade 2 when spleen is palpable but not beyond the horizontal line halfway between the costal margin and umbilicus. We have to draw the horizontal line between the costal margin and umbilicus, and if spleen is not crossing this line, then we will label as a grade 2. Grade 3 when spleen is palpable more than halfway to the umbilicus, almost just near to the umbilicus and crossing this line between the costal margin and umbilicus but not crossing the line through the umbilicus. So we have to draw the horizontal line through the umbilicus, and when spleen is not crossing this second line, that means it is grade 3. Grade 4 when spleen is palpable below umbilicus but not below the horizontal line halfway between the umbilicus and the pubic symphysis. So we have to draw the three horizontal lines over the abdomen, one between the costal margin and umbilicus, second at the level of umbilicus, and third one between umbilicus and pubic symphysis. So if spleen is palpable during deep inspiration, we will label as a grade 1, not palpable, grade 0. Grade 2, when spleen is easily palpable but not crossing this first line between the costal margin and umbilicus, we label as a grade 2. When spleen is beyond this line towards the umbilicus but not crossing the line at the level of umbilicus, we label as a grade 3. When this spleen crossing this second line through umbilicus but not crossing the line between the pubic symphysis and umbilicus, we label as a grade 4. And when the spleen is even crossing this line between the umbilicus and pubic symphysis, huge spleen, we label as a grade 5. So this is Hackett grading for the splenomegaly. Whenever liver and spleen are palpable, we should also keep in mind, is it actually enlarged liver spleen or it is pushed down liver spleen which is palpable. So we label as a visceroptosis whenever pushed down liver spleen are palpable. So it occur in the rickets when ligament laxity is there, when subdiaphragmatic abscess, emphysema, pneumothorax, pleural effusion, all these conditions will push down the liver spleen, and during abdominal palpation both will be palpable but actually not enlarged. Now how to approach isolated hepatomegaly, or we can say what are the various causes of isolated hepatomegaly. So whenever there is an isolated hepatomegaly, we should keep in mind that isolated hepatomegaly can be because of liver disease, can be because of push down liver, or can be because of cardiac conditions. And we know cardiac condition is an emergency, so always we have to look for the other signs of cardiac conditions. Example, if the patient is having cardiac tamponade constrictive pericarditis, then patient will have the tachycardia, tachypnea, pericardial rub, all will be with the hepatomegaly. And in CCF, patient will have the raised JVP with tachycardia, tachypnea, and hepatomegaly. So whenever there is a isolated hepatomegaly, perform the cardiac examination also. Another is push down lever, which is seen in the pneumothorax subdiaphragmatic abscess or in the pleural effusion. So examine the respiratory system also for the pneumothorax and pleural effusion. Maybe decreased air entry, patient is having distress and the bulge on the same side of the chest. You should suspect pneumothorax or pleural effusion. In such case, push down lever will be there. And when there is a subdiaphragmatic abscess, again patient will have the respiratory distress and patient will have the fever, high grade with the chills rigor. All such thing will be associated with this. If you have ruled out the cardiac causes and you have ruled out the push down lever, then think about the hepatic disease. Now, if the patient is having hepatic disease without sign of hepatic dysfunction, means when you will go for the liver function test, LFT is normal and patient is having hepatomegaly and tenderness in the liver, and USG is also suggesting that hepatomegaly, then causes are different. And with the signs of hepatic dysfunction means a altered liver function test. So when there is a without sign of hepatic dysfunction means there is no icterus, normal color of the urine as a stool, then rule out the pyogenic liver abscess, amoebic liver abscess, fasciola hepatica, hydrated cyst, hemangioma, and glycogen storage disorder can also lead to the similar presentation. With the signs of hepatic dysfunction, means icterus is there, urine stool color is also changed, then either hepatic or biliary. So if hepatic with fever, then viral hepatitis, hepatitis A, B, C, D, E, which are common, Epstein-Barr virus. Without fever, then rule out the Wilson disease, veno-occlusive disorders, or alpha-1 antitrypsin deficiency. So rule out all these causes. If hepatic is ruled out, then see the biliary tract. Biliary atresia can also lead to the changes. So whenever there is a hepatic, then stool color will be yellow. When there is a biliary involvement, stool color will be clay or white, while the urine will be yellow in both hepatic and biliary. And icterus will be present in both. Biliary will lead to the cholestasis, direct hyperbilirubinemia generally. In hepatic, direct or indirect, both can be seen. Now, according to the consistency, surface, and margin of liver, we should know what are the differential diagnoses. Firm liver seen in the tuberculosis, cirrhosis, in hemolytic anemia, hard liver with the malignancy, nodular liver means cirrhosis or malignancy, tender liver means congestive cardiac failure or infection, abscess, hepatitis will lead to the tender liver. Rubbly surface seen with the trauma, malignancy, infections, and sharp leafy margin seen with the cirrhosis and malignancy. Now approach to only hepatomegaly with minimal splenomegaly. So when there is a either only hepatomegaly or hepatomegaly with minimal enlargement of the spleen, means mainly liver is enlarged, but spleen is also mildly enlarged. We label as a hepatosplenomegaly. Example in infections, viral hepatitis, HIV, dengue, typhoid, leptospirosis, tuberculosis, amoebiasis. Congestive CCF, constrictive pericarditis, infiltrative nutritional fatty infiltration, fatty liver disease, glycogen storage, malignancy, cirrhosis, early congenital hepatic fibrosis can lead to this, Budd-Chiari syndrome, hydrated cyst. Now approach to isolated splenomegaly or massive or moderate splenomegaly with mild hepatomegaly. We label as a splenohepatomegaly. So in the isolated splenomegaly, according to the mild, moderate or massive splenomegaly, there are various differential diagnoses. So when mild splenomegaly less than 2 cm, we should keep in mind common causes, typhoid, malaria, systemic juvenile idiopathic arthritis, and thalassemia minor. Moderate size of spleen between 3 to 7 cm can be because of portal hypertension, extrahepatic hemolytic anemia, leukemia, zoonosis, lipid storage diseases, or sometimes double heterozygote hemolytic anemia. Massive splenomegaly more than 7 cm in size. Always keep in mind these 5 common causes: thalassemia major, tropical splenomegaly because of chronic malaria, CML, Gaucher, and Niemann-Pick disease. Whenever there is a isolated splenomegaly with fever, then if it is associated with the lymph node enlargement, then think about leukemia, infectious mononucleosis, torch group of infection, and SLE and systemic GIA. If it is without lymph node enlargement, then think about malaria, typhoid, and subacute bacterial endocarditis. Then according to the etiology also, we have to rule out various infections of the virus, bacteria, and parasite and fungal can lead to the splenomegaly, hematological disorder, hemolytic anemia, Rh-ABO incompatibility during neonatal period, infiltrative disease, leukemia, lymphoma, storage disorder can lead to the splenomegaly. Hyperplasia of white pulp, example in sarcoidosis, congestion due to the portal hypertension, liver cirrhosis, fibrosis, and immunologically mediated disease, systemic JIA SLE can lead to the splenomegaly. So according to the etiology also we have to keep in mind, and according to the size also we should keep in mind. Now last is approach to hepatosplenomegaly. When hepatosplenomegaly associated with anemia, then think about with fever. So in malaria, leukemia, disseminated tuberculosis, sepsis, infectious mononucleosis, toxoplasmosis, patient will have the hepatosplenomegaly with anemia with fever. Now without fever, think about hemolytic disorder, thalassemia, hereditary spherocytosis, sickle cell. Then think about glycogen storage disorder, Wilson disease, or leukemia. If hepatosplenomegaly with anemia in less than 2 months age group, think about Rh-ABO incompatibility, hereditary spherocytosis, TOJ group of infection, inborn error of metabolism. In more than 2 months age group, lipid storage disorder in which vision loss will be present, MPS mucopolysaccharidosis in which corneal opacity, bony deformity all will be there, leukemia when lymph node and petechiae will be there, malaria when fever will be there, TB when the patient is FTT malnourished, infectious mononucleosis associated with lymph node enlargement, brucellosis will present as a PU and lymph node will be enlarged, and systemic GIA. Hepatosplenomegaly with rashes. With fever, think about toxoplasmosis, CMV infection, infectious mononucleosis. Without fever, then SLE or hemophagocytic syndrome. Now hepatosplenomegaly with lymph node, think about leukemia, infectious mononucleosis, torch and brucella. Now according to the associated symptom onset, we can differentiate either it is due to the infections where the fever, and we have to differentiate according to the onset, is it viral, bacterial, parasitic. In hematological, patient will have the manifestation of pallor, bleeding, lymphadenopathy, mild fever, jaundice, recent blood transfusion, failure to thrive, and according to the age of onset we can differentiate the which hematological disorder is. In congestive hepatosplenomegaly, due to cirrhosis with portal hypertension, there will be chronic history. Patient will have the all manifestation of the involvement: jaundice, ascites, hematemesis, anorexia, weight loss, caput medusae, gynecomastia, spider nevi, and signs of various vitamin deficiency. In infiltrative lymphoma, patient will have the fever, lymphadenopathy, various systemic symptoms. So this is all about approach to the hepatosplenomegaly. Thank you so much.